The Rh system. The D antigen within the Rh blood group system is the most immunogenic of all blood group antigens, meaning it has the highest potential to stimulate an immune response. Accurate D typing is essential for safe transfusion practices and prenatal care. Testing methods for D antigen. D typing is typically performed using either the immediate spin method or the anti-human globulin AHG phase. These methods help determine whether the D antigen is present on a person's red blood cells. Weak D phenotype. Some individuals may have a weak expression of the D antigen, known as weak D. This condition requires special consideration. If a sample tests negative at immediate spin but positive at the AHG phase, it is considered weak D positive, provided the D control is negative. Blood donors must be tested using the AHG phase or a sensitive weak D method to ensure accurate classification. Patients, however, do not need to be tested for weak D. If they test negative at immediate spin, they are treated as D negative and can receive D negative blood products. All infants born to D negative mothers must be tested for the D antigen to assess risk for hemolytic disease of the newborn. Any result that is weak D positive should be recorded as D positive. Monoclonal and polyclonal anti-D reagents. Modern D typing often uses monoclonal or monoclonal/polyclonal blend reagents. These reagents simplify testing and reduce the need for separate controls. A separate D control is not required for patients with A, B, or O positive blood types. If a patient shows a negative reaction with anti-A and/or anti-B reagents, this serves as the negative control, confirming that the patient's cells are not spontaneously agglutinating. A D control is required for patients who are AB positive or for any ABO type that tests negative at immediate spin for the D antigen. In these cases, testing must continue through the AHG phase to detect weak D. For AB positive patients, appropriate controls include a 6% albumin control, an autocontrol, a direct antiglobulin test, DAT. This is because AB positive patients will naturally react with both anti-A and anti-B reagents, making it impossible to use those reactions as a negative control. The most common reason for a positive DAT control is a positive DAT result, indicating that antibodies are already bound to the patient's red cells. High-protein anti-D reagents. Historically, high-protein anti-D reagents were used for D typing. These have largely been replaced by monoclonal or monoclonal/polyclonal blend reagents, which are more reliable and cause fewer false positives. If high-protein reagents are still used, it is essential to use the same manufacturer for both the anti-D reagent and the control reagent to ensure consistency and accuracy. Unusual Rh phenotypes. Some individuals exhibit rare Rh phenotypes that affect the presence of Rh antigens on their red blood cells. Rh null phenotype is characterized by the complete absence of Rh antigens, including D, C, EC, and lower E. Because the Rh structure is an integral part of the red blood cell membrane, individuals with this phenotype often experience hemolytic anemia, a condition where red blood cells are destroyed faster than they can be produced. Deleted cell phenotype, often referred to as D double negative, involves the absence of one or more normal Rh alleles. This can complicate blood typing and transfusion compatibility, requiring advanced testing methods to identify and match donors. Rh antibodies. Antibodies directed against Rh antigens are typically of the IgG class, which are clinically significant due to their ability to cross the placenta and cause hemolytic disease of the fetus and newborn. These antibodies may agglutinate red blood cells at body temperature, which is approximately 37 degrees Celsius, and also during testing with anti-human globulin, AHG. Certain Rh antibodies, specifically anti-C, anti-E, and anti-lower E, tend to react more strongly when the red cells have been treated with enzymes, which enhances antigen exposure and improves detection. The Lewis blood group system. The Lewis antigens, Specifically, Lewis A and Lewis B are plasma antigens that adsorb onto red blood cells rather than being produced directly by them. Importantly, Lewis A and Lewis B are not alleles, meaning they do not represent alternate forms of the same gene. Lewis antigens are not present on cord blood cells, which has significant implications for pregnancy and neonatal care. Lewis antibodies have several notable features. They do not cause hemolytic disease of the fetus and newborn, HDFN, because Lewis antigens are absent from fetal cells, and the antibodies are typically of the IgM class, which does not cross the placenta. Although IgM antibodies are generally less concerning, they can be hemolytic in some cases. Lewis antibodies are usually found in individuals who are Lewis A and B, meaning they lack both Lewis A and Lewis B antigens. These antibodies are often seen in pregnant women who may temporarily become Lewis A or B due to changes in antigen expression during pregnancy. The eye and lower eye blood group system. The eye and lower eye antigens are part of a developmental system that changes as a person matures. The eye antigen is absent or weak on cord blood cells. As infants grow, the lower eye antigen gradually converts to eye through the branching of carbohydrate chains on the red cell surface. Importantly, lower eye and eye are not alleles. This developmental shift means infants are typically lower eye positive and eye negative. Adults are generally eye positive and lower eye negative. Antibodies in the eye or lower eye system include anti-eye, which is an IgM cold reactive antibody. It reacts with all adult red cells, except in the rare case of a lower eye positive adult. Anti-eye can mask clinically significant alloantibodies, making it harder to detect other important antibodies during testing. To remove anti-eye and uncover underlying alloantibodies, several techniques may be used. Autoadsorption, which is appropriate if the patient has not been recently transfused. Allogeneic adsorption, using donor cells. Rest adsorption, which involves using IgG antihuman globulin instead of a polyspecific reagent during pre-warming. However, this method must be used with caution, as it can reduce the activity of some clinically significant antibodies or cause weak antibodies to be missed. The P blood group system. The P1 antigen is known to weaken over time when red blood cells are stored. This deterioration can affect testing and antibody detection. Antibodies in the P system include anti-P1, which is an IgM cold reactive antibody. It does not react with all P antigens and can be neutralized using substances found in hydatid cyst fluid. This neutralization helps reveal other clinically significant alloantibodies that may be masked. Anti-P, on the other hand, is an autoantibody of the IgG class. It is known as the Donath-Landsteiner biphasic antibody, which is associated with paroxysmal cold hemoglobinuria, a rare condition. This antibody reacts with all cells that are positive for P or P1 antigens. The MNS blood group system. The MNS system includes M and N, as well as S and lower S, which are codominant alleles, meaning both can be expressed simultaneously. Antibodies in this system include anti-M and anti-N, which are typically cold reactive IgM antibodies and do not cause hemolytic disease of the fetus and newborn, HDFN. These antibodies often show dosage, meaning they react more strongly with cells that have a homozygous expression of the antigen compared to those with a heterozygous expression. Additionally, they do not react with enzyme-treated cells, as the M and N antigens are destroyed by enzymes. Anti-M can also appear as IgG, and in such cases, it can cause HDFN. The reactivity of anti-M increases when the serum is acidified. Higher anti-S and lower anti-S are IgG antibodies, as is anti-U. The anti-U antibody is typically formed by African American individuals who lack the S, lower S, and U antigens. The Kell blood group system. In the Kell system, K and smaller k are also codominant alleles. A large majority, approximately 91%, of blood donors are K negative, meaning they do not express the K antigen. The Kell antigens can be inactivated using chemical agents such as 2-mercaptoethanol, 2-ME, dithiopteritol, DTT, or 2-aminoethylisothioronium bromide, AET. Antibodies in the Kell system are typically of the IgG class, which are clinically significant and can cause transfusion reactions or hemolytic disease of the fetus and newborn. The KID blood group system. The KID system includes two antigens, JKA and JKB, which are codominant alleles. This means that both antigens can be expressed simultaneously if inherited from different parents. Antibodies in the KID system have several notable characteristics. They are of the IgG class, making them clinically significant. These antibodies tend to react more strongly when red blood cells are treated with enzymes, which enhances antigen exposure. KID antibodies are known for their rapid fluctuation in titer levels, meaning their concentration in the blood can rise and fall quickly. They are commonly associated with delayed transfusion reactions, which may occur days after a transfusion. KID antibodies often show dosage, meaning they react more intensely with cells that have a homozygous expression of the antigen compared to those with a heterozygous expression. The Duffy blood group system. The Duffy system includes the antigens FYA and FYB, which are also codominant alleles. These antigens are destroyed by enzyme treatment, making enzyme-based testing less effective for detecting Duffy antigens. A significant portion of the African American population, approximately 68%, have the FYA or B phenotype, also referred to as FYFY, meaning they lack both Duffy antigens. This phenotype is associated with resistance to certain strains of malaria. When performing antigen typing, individuals who are FYA plus B- and of Caucasian descent are typically homozygous for FYA, meaning they inherited the FYA antigen from both parents. Individuals with the same phenotype who are African American are more likely to be heterozygous for FYA, having inherited the antigen from only one parent. This can lead to dosage problems, where antibody reactions may be weaker or inconsistent. Antibodies in the Duffy system include IgG antibodies, which are clinically significant. Weaker examples of these antibodies may also show dosage, reacting more strongly with homozygous cells. Duffy antibodies typically show a negative reaction when tested with enzyme-treated cells due to the destruction of the antigens.